Hello and welcome to the module ODO 570, the Division of Endodontics. I'm Dr. Buchanan, and today we're going to be talking a little bit about advanced obturation. As always, I like to start with a slide or a case, and I ask you, is this a good obturation? Clearly not. When we have a look at it, we can see that there's only a single cone in. It is going to length, but we can see that there's quite a lot of space around this cone that hasn't been adequately cleaned and shaped, and the obturation clearly is inadequate in this case because the GP and sealer that was used is way too small for the canal that was treated. And of course, straight line access here wasn't great either. Does it matter how well we obturate? I think it does. Early thoughts considered obturation to be one of the most important steps in the root canal treatment process. However, as we had a look at in the outcomes lecture, seemingly poor obturation can very often result in clinical success. And why is this? It's not so much a matter of what you put in, but rather what you take out of an endodontically treated tooth. So any tooth that we do a root canal treatment on that becomes free of bacteria or irritants are often completely symptomless, and regardless of how poor an obturation may look on a radiograph, if that tooth has been cleaned out nicely, the case can still work over a longer period of time. So if there's no active infection, there'll very often be no symptoms. And some very questionable root canal treatments that have a good coronal seal have lasted a really long time. But make no mistake, your obturation does matter. Just because we have some cases where questionable treatment worked, this doesn't mean we can accept poor quality obturation as a routine. Remember, we have to provide both a good coronal seal and a good apical seal, and both of these are important for endodontic success. We know from our research from studies that it's impossible to remove all the microorganisms from the root canal system. Therefore, a good obturation can entomb any of the bacteria that remains in the tooth after we've cleaned and shaped, and this will prevent their escape either apically, which can cause an apical periodontitis, and not allow any new bacteria to get into the tooth from the top, from the coronal aspect. Today we're going to focus a little bit on advanced obturation techniques. In order to get to our advanced techniques, let's just cover what used to be done in the past. So a long time ago, silver points were used to obturate teeth. You can see this in the radiograph on the right-hand side. Paste fillers or sealers only have been described before. That's basically where no gutta percha is used and only the sealer is mixed, or the sealer is mixed into a paste consistency and then placed into our canal system with something like a lentular spiral. These were horrible techniques because they really created lots of voids. You had no control over your length, and they could often extrude large amounts of sealer through, and this sometimes even entered vital structures like your inferior alveolar nerve and caused paresthesia. The single cone technique fell out of favor. It was described a long time ago initially, but it fell out of favor with our traditional sealers because the sealers could resorb. And then, of course, there's the cold lateral condensation technique, which you guys are all very familiar with. Cold lateral condensation, it's the technique that forms the backbone of the undergrad program, and typically in this technique we're using either greater taper. We can use F1 or F2 points with cold lateral condensation if you use an F1, for example, as your master GP, or you could use 2% taper GP points that are all coated in sealer, and then you can add accessory points in that are a little bit smaller and condense all these points together in order to make a nice sealed canal, and that's giving us a nice waterproof barrier. The technique can and does still work very nicely. It obviously does, because this is why we teach you guys this technique. Here's a case of mine from when I was still in private practice, where I used cold lateral condensation in the distal canal and single cones in the mesial canals. And you can see, even with cold obturation techniques and with these classic techniques, we can actually get really nice results, and we can even fill lateral anatomies as well. There can be some challenges with cold obturation, and this is especially prevalent when we're using a single cone technique with our conventional sealers. And the trouble was that the sealers resorbed, so therefore using a single cone didn't provide us with enough volume. One of the challenges that we have as well is our anatomy of our teeth. So we know that rotary and reciprocating instruments that we use, something like your ProTaper rotary files, prepare a canal to be artificially round, and this is well demonstrated in the picture on the right hand side. But bear in mind that root canals and canal systems are not naturally round to start with. Most are in fact oval and some are ribbon shaped. We depend heavily therefore on our irrigation to work for us and clean these spaces in between, or any isthmuses or deltas or fins or communications that we can have between canals. But if you think about it carefully, if you have a canal that's been prepared round in diameter, in your oval or ribbon-shaped canals, the canals that were naturally shaped that way, it's going to leave gaps between our GP points, because our GP points are also designed to be round, much in the same way that our files are. And the sealer is supposed to occupy the spaces in between these GP points. So if we're using cold lateral condensation, we're supposed to be adding in more gutta-percha, and that's supposed to fill these spaces, especially apically. And it can be quite difficult to do this well with only cold techniques. This is from Endodontics Principles in Practice, your prescribed textbook, and it just describes what we're trying to achieve with a good cold lateral condensation. Remember, the canals are often oval, and the GP points that we use are round. So we have to condense these round GP points, first with the master GP points and then some accessory points into it. And we're trying to get as many in as possible so that we can fill up all the space. And hopefully the space in between all these GP points is filled with sealer as well. What are the challenges with the conventional sealers that we use? Your conventional sealers tend to resorb over time, and they don't actually bond to your dentine, and most of them are hydrophobic. So this causes a leakage problem in the long term. Attempts have been made to improve sealers over time. So we started with zinc oxide eugenol sealers, something like your ROTS or your Endomet Plain, and over time stuff like calcium hydroxide was added to it to make something like Sealapex, demonstrated in the middle picture. And then even resin-based sealers were created later on, like your AH+. But the trouble with all these sealers, whether it's zinc oxide eugenol, calcium hydroxide, or resin-based, is that they don't seal as well as we want them to. Numerous studies over many, many years have shown us that these conventional sealers don't seal very well. In order to counteract this problem of sealer leakage and the fact that sealers resorb, the philosophy evolved to try to reduce the interface between the gutta-percha and the sealer. And your cold lateral condensation was really the first attempt at doing this, so that is adding in more GP and having less sealer. So the idea is we use as little sealer as possible because the sealer is the weakest link, and then the warm techniques were developed from that in order to make the mass of the GP more and to make the GP warm and flowable so that it could take up more space in the system and reduce that interface between the gutta-percha and the sealer. And overall, there would be less shrinkage and by extension, less leakage and a better seal in the long term. Warm obturation techniques were pioneered by Dr. Herb Schilder in the United States in the 1960s. And in this technique, gutta-percha is thermoplasticized using heat. And a series of heated hand pluggers in the very original technique were used to sequentially condense warm gutta-percha into the canals and the canal systems. So this is what I'm talking about. Hand pluggers were used basically to heat up our GP and to move it into spaces. These techniques have been modified and simplified over time. However, all our warm techniques employ this common concept of we're heating up our GP, we're increasing the mass of GP and reducing the interface between the gutta-percha and the sealer. The following techniques have been described when we talk about warm obturation techniques. The very first one is only very technically a warm obturation technique. It's a historical technique. I'll talk about it in a couple of slides, but it's the chloroform dip technique. Then we have warm vertical condensation with hand pluggers. Warm vertical condensation can also be achieved in modern times with heatful systems, and then carrier-based obturation. The chloroform dip technique, remember, you should know from your retreatment lectures that chloroform is used in the retreatments of root canals, and it's used in order to chemically soften and or remove gutta-percha. So remember, if it can soften GP, it can also be used to soften GP points. So historically, in larger sort of open apex cases where you had an apex that was maybe a size 70 or an 80 ISO diameter, a master GP was selected. The terminal third of this master GP was then dipped in chloroform for 1 second. That allowed chemically for the GP to be softened, and then this gutta-percha that was now soft was inserted into your canal. It took an impression of your canal or of your apical anatomy, and then it was removed again. The excess Chloroform was removed with alcohol and it was allowed to air dry for about 30 seconds, and thereafter your sealer was applied into your canal and onto your GP point, and the case was obturated with cold lateral condensation. Please bear in mind that this is just an academic example. It's a historical technique and it's no longer used routinely. Then our warm vertical condensation could be achieved with hand pluggers. I'm going to show you an animation in just a few slides to better demonstrate the technique, but we could do them with hand pluggers, or we could use heat-fill systems, which are more commonly available today. So something like a calamus deal that's made by bioceramic. You'll see it's got two basic hand pieces on it. The hand piece on the left-hand side is a heated probe that's used during the downpack of the GP, and this will be better explained in a second. And the hand piece on the right-hand side is a backfill system, and that's actually used to express thermoplasticized or warm GP into your canal. We're going to have a little look at the technique now. It's warm vertical condensation. So this applies to whether you're doing it with hand pluggers or if you're doing it with heat-fill systems. The videos are courtesy of bioceramic Endodontics. So the first thing that gets done is pluggers are fitted. In the coronal, quite a large plugger is fitted. Then in the middle third of the tooth, a medium-sized plugger is fitted. And then for the apical area, quite a small size hand plugger is fitted. And it has to reach to within more or less 5 mils from the apex. We fit a GP point, we make sure that it has tug back and good resistance, that you can't push it through. Thereafter, sealer is placed into the canal with a paper point, but only a minimal amount of sealer. The master GP is coated with sealer and placed to length. It needs to be seated firmly and positively, and then it's seared off at the orifice level. And you'll notice when you sear it off, it heats that coronal third of GP. A large plugger that's used in the coronal third is then used to pack the GP downwards. So this is a down pack, and that will condense the coronal third of GP. The next portion of the GP is then removed, and that heats up the middle third. Then the plugger that was fitted in the middle third is used to vertically condense the gutta percha apically. And then the smallest plugger is heated up. That's brought to within 5 mils of the apex. Some GP is removed, and then that heated GP in the apical 5 millimeters is then nicely condensed. And you'll see that that causes the gutta percha to flow, and it pushes it into the lateral canals. So in this technique, the coronal and the middle third of the GP is therefore removed in a stepwise fashion, and each time it's removed, it heats up the layer that's more apical to the layer that's being removed, and this allows us to condense this GP vertically. After the downpack has been achieved, the rest of the canal can be backfilled with warm GP. So this is where you'd use a backfill device that expresses heated GP. So you can express maybe 2 or 3 millimeters of GP into your canal, condense it downwards, and then repeat that process in the middle and coronal thirds. So a little bit more gutta percha can be expressed. That's warm gutta percha. You can condense it down into the middle third, packets, and then finally the coronal third can be filled with GP, and that can be condensed downwards. And that's your classic warm vertical condensation technique. As you can see with this technique, you don't use a lot of sealer. Quite a small amount of sealer is used, and the fill is largely composed of heated gutta percha. This technique provides a very good dense obturation. However, it can be a bit technique sensitive. As you could see, it can be quite difficult to master if you haven't done it before. Alternatively, another warm technique that we can use is called the continuous wave of condensation technique. It's basically a modified and simplified version of the classic warm vertical technique. In this technique, a plugger is pre-fit before you put GP into the canal to extend to within 5 millimeters of your final working length, and then your master GP cone is fit. You determine strong tug back at working length and resistance, so you make sure that you can't push it through, and then you can burn off the GP at the apical third from the beginning, and I'll show you the technique in just a second. So here it is, your GP has been placed and sealed off. So in continuous wave condensation, you take your heated probe to within 5 millimeters of your apex. Allow it to cool down. You're going to give a short burst of heat again to heat that GP up, rock your plugger left and right, and then remove it. And in this way, you can remove actually the coronal and the middle third of the GP, and at the same time you've heated up the apical gutta percha and you've condensed it downwards. So you're doing basically the same thing that you've done in the classic warm vertical technique, but you've done it in less steps. And at this point we can backfill the case. So the backfill, when you're using continuous wave condensation, proceeds in exactly the same fashion as the classic warm vertical technique. So about 3 or 4 millimeters of gutta percha is placed and then condensed apically. The middle third can then be filled and condensed vertically again. And then finally the coronal third can be filled up. So these are your two most common warm vertical filling techniques. Challenges, the warm techniques can provide you with an excellent obturation. You really can get very nice results when using the technique. The pluggers, however, if you use them incorrectly, can cause root fracture. In this technique, your canals need to be opened quite large, to a relatively large taper, to allow the pluggers to fit to within 5 millimeters of working length. This can clearly be quite difficult if you have severely curved canals, and that limits the use of the technique. And obviously, it heats up to very high temperatures. The heated pluggers are used between 200 and 230 degrees Celsius, so incorrect use of the heated pluggers can actually cause thermal damage to yourself or to your patient. These techniques must be mastered. It takes practice. You can't just learn them in a day. You'd have to practice them a little bit before you try to use that on patients. And then the equipment and the consumables in these techniques can be a lot more expensive than doing the cold lateral condensation technique. Carrier-based techniques, another way of doing warm obturation is to use a carrier. So that's something like a core that's made of plastic or cross-linked gutta percha. In this particular example, I'm showing you a gutta core. So this is a carrier that's got a plastic handle and a silicone stopper. Then the gray bit that you see in the middle is actually cross-linked gutta percha that is gray. So it is GP, but it's a special kind of GP. That GP in the middle that the core is made of can't be softened. And then wrapped around that, the orange bit that you see is alpha phase gutta percha, and the alpha phase gutta percha can actually be heated up. Historically, back in the day, they did make metal cores as well, but we don't use the metal cores anymore, and very seldom these days, I think, do we even use the polysulfone cores. The plastic carriers, or the polysulfone, was called thermophil. Either your thermophil or gutta core points, but I would recommend gutta core if you do want to use this technique. It's then heated in this oven that you can see pictured on the right hand side. So the gutta percha is placed onto that little holder for it. The holder is depressed into the oven, and the oven actually heats up to about also between 150 and 250 degrees Celsius, depending on how thick your GP is. And then this heats up that alpha GP that's wrapped around the outside. When you use this technique, a minimal amount of sealer is also placed into the canal, because remember, we don't need a lot of sealer because we're using a lot of GP. And it's advisable, if you do use this technique, I did in private practice, always set your stopper 1 millimeter short of your final working length, and then you can gently push this carrier to your full working length over a period of 2 to 3 seconds. So you have to do it not too slowly, but also not very quickly. You have to introduce it in a slow, controlled manner. This is what happens if you use too much sealer. The technique can very nicely fill your lateral canals and your apical anatomy, but you need to be careful. Do what I say, not what I did. Use quite a small amount of sealer. So if you use too much sealer, you're going to get quite a lot of sealer extrusion in these cases. Well, over time, I got better with it. Practice makes perfect. It is unfortunately about 120 Rand per carrier, so that's per gutta percha points if you're using this carrier-based technique, so something like a gutta core or a thermophil. So it can be quite an expensive technique. One of the drawbacks of it is that retreatment may be challenging because you now have this core. You're not just trying to remove GP, but you have to try to remove that plastic core or that cross-linked gutta-percha core, and that can be tricky at times. And it can even lead to complications with post-space preps. You actually get special burrs that are designed to remove carrier-based obturations if you want to prep a post-space. So that was some of the challenges with using the technique. So if we look at our warm obturation techniques that I've shown you now, all these techniques improve the obturation of the root canal system, and it reduces the problem of shrinkage when you are using conventional or traditional sealers, simply because you're using less sealers. A bit more recent developments look beyond the gutta-percha and the sealer interface, however, and let's talk about them in the following slides. In the mid-1990s, MTA was introduced, and the material was a breakthrough. It changed the way that perforations, apical surgery, and procedural accidents were treated. It was based on the chemistry of Portland cement, so that's basically the PPC cement that's often used in construction. And MTA was really a great material, but it was a root repair material, and it continues to be. Therefore, there's several challenges if you want to try and use MTA as a sealer in combination with GP, and that was that MTA has quite a long setting time. It takes about 4 hours to set. It has a grey color, so its radio opacifier is bismuth oxide, and that actually causes the crowns of the teeth to discolor. If you've never used it before, MTA is not an easy material to use. It's quite technique sensitive. You have to mix it to a wet sand consistency, and it sort of dries out quite quickly, and then you lose your consistency and you have to add a little bit more liquid. So it can be quite a tricky material to work with, and at around 850 Rand for a pack or for a gram of MTA, it can start to become really expensive if you want to use this as a sealer in all your canals. The concepts and the chemistry that underpin MTA were refined and extended to our endodontic sealers in recent times. And I'm talking about our bioceramic sealers. Bioceramic sealers have several advantages over our traditional sealers. And that is that when we use this material, we don't have to reduce the interface between the gutta-percha and the sealer as much, because the sealer acts as a filler. And it can act as a filler because bioceramic sealers don't shrink and they don't resorb over time. In fact, some of them can even expand slightly. They're highly biocompatible because they're based on the chemistry of MTA. They're hydrophilic, which means they're water-loving, which is good because remember, our dentinal tubules are still full of fluid. They're antibacterial, has a nice high pH of around 12, and it causes a setting reaction that actually makes a bit of a chemical bond to your dentine. So it adheres very well to our dentine. It gives us a very nice seal. The cost of using the sealers is lower as compared to trying to use traditional MTA. And for the first time, we can now use a single cone technique if we use a bioceramic sealer because of the properties that I've just mentioned. It goes through a setting reaction that actually has two reactions in it. There's a hydration reaction, and as part of the hydration reaction, calcium hydroxide is formed, which is antimicrobial and has a nice high pH. And then it precipitates, and when it precipitates, it forms hydroxyapatite, and that allows us to adhere to the tooth structure and gives us that nice biocompatibility. Here is the setting reaction. So you can see there, I've just highlighted the importance of it in the hydration reaction. It's a calcium silicate material, so the calcium silicate molecules pick up water. That makes a calcium silicate gel, and as a byproduct, calcium hydroxide, which is highlighted in red. And it's that calcium hydroxide, it's the same as the calcium hydroxide that you mix as an inter-appointment medicament, and it has the same properties. It allows the material to be antimicrobial, and it gives it a nice high pH. And then during the precipitation reaction, that calcium hydroxide actually interacts with the calcium phosphate ions in the material, and the green molecule that's formed is hydroxyapatite. And the byproduct of the precipitation reaction is water, which can then be used in the hydration reaction again. So it's actually quite a nice material. It's got quite an elegant chemistry. With our bioceramic sealers, we can use a single cone technique, and this makes them very easy to work with. And it's very similar to the technique that you guys are already using in the 5th floor ward. So you match a single GP cone of similar size to the last rotary file that you've used. So let's say you used an F3 or an F4. On a case, you're going to use an F3 GP cone. use a small file to first pick up the material and generously coat the walls of the canal, because remember, we have to use more material when using this technique, so more sealer. It's not a warm technique, it's a cold technique. Coat your master GP in the bioceramic sealer and insert it down to working length. It's quite simple. Then you can just sear it off, remove any excess on your axial walls with ultrasonics and water, and remember to use, as I said, a moderate amount of sealer, because remember, this sealer now has to occupy the space if you want to use a single cone technique that would have been occupied by your accessory GP points if you were using cold lateral condensation. And this is what I'm talking about. So remember, you're going to have only a single gutta-percha point, which is round, but most often we're working in oval canals, and then the bioceramic sealer, which doesn't shrink and doesn't resorb, is going to occupy the rest of the space around the gutta-percha. So you can actually start to appreciate from this picture why it's a problem if we do single cone technique with our traditional sealers, because they can resorb, but our bioceramic sealers don't resorb, so it can actually give us a nice fill. Here's just a pre-prepared plastic block that's been obturated with a single cone and bioceramic sealer. I did have a video of how this technique works, but the video is quite large, so I didn't include it in this online presentation because it's going to use way too much data to upload. Debate. There are some concerns of increased voids when using a single cone technique. In fact, there's a lot of disagreements in the endo world between the philosophies of cold obturation and warm obturation techniques, although I think a lot of that has to do with the instrumentation and not so much the sealers. A 2017 systematic review found our bioceramic sealers to be similar or better as compared to our traditional sealers. And in 2018, a study with a 30-month average follow-up showed about 90% success rate when bioceramic sealer was used, so we can get good outcomes when using this material. I think the most important paper is the meta-analysis by Peng in 2007 that showed that there's no difference in the clinical outcome between cold lateral condensation, so a cold technique, and warm obturation, except that we had a slightly increased tendency of overextension with gutta-percha in our warm techniques, but that just makes sense because that's how that procedure is performed with vertical compaction. So the evidence doesn't really take us one way or the other, whether we're using cold or warm techniques. Pitfalls of bioceramic sealers. Retreatment can be more difficult. Remember, the material adheres very well to our dentinal walls and it sets a little bit harder than our traditional sealers, so retreatment can be challenging, especially if you have obturated the case short. So always get nicely to your full working length if you're going to consider using bioceramic sealers, otherwise a retreatment can be difficult. The product is more expensive than our conventional zinc oxide, eugenol, calcium hydroxide and resin-based products. And as we mentioned, if your canal isn't 100% cleaned and disinfected properly, it will be more difficult to retreat the tooth or to get back in there to treat the flare-up. But these materials do show great promise. Some clinicians have actually combined warm obturation techniques, so something like your warm vertical compaction or your continuous wave condensation or even the carrier-based techniques with the use of bioceramic sealers instead of traditional sealers. But I want to mention that if you're thinking about doing that, if you get out into private practice, long-term data is not yet available on combining the techniques. I have, however, combined bioceramics with warm techniques in the past. This particular case was an apexification procedure. As you can see, a nice wide open apex. The file that I used to take the working length there is a size 140 ISO K file. Therefore, it was going to be really difficult just to get a nice seal with either a warm or a cold technique, so packed MTA as an apexification procedure. So that's a bioceramic, and we backfilled the canal with warm thermoplasticized GP. So this is a bit of a combination technique. In this particular case, I also combined bioceramic sealer with a warm technique. So I used the bioceramic sealer and I used it basically as a single cone technique on the canal pictured on the right hand side. This is a 3-5, by the way, with 3 canals. But there in the mesial canals, we actually had one that was going lingually and one that was going buccally, and you can see that the canals only split about halfway down the root. So here I used a combination technique. I did use bioceramic sealer, but I did also use a continuous wave condensation, and then I filled the common portion of the canal actually with heated GP as well with a backfill technique. So it is possible to combine the techniques of bioceramics with warm obturation techniques. I always like to share these special techniques. This is the case of super long canine. I put it in the lecture every year. I quite enjoy it. This is a patient with oculofaciocardiodental syndrome. So that's a genetic disorder that obviously leads to problems with the eyes, face, hearts, and teeth. And one of the problems that we have with teeth is that they present with radiculomegaly, or really long teeth. You can note there on the pan, have a look at the mandibular canines. So in this particular case, the 4-3 required a root canal treatment. It had developed a pulpitis, and you can see how long it is. That's not a periapical, that's a cropped pan. And when they started to do the root canal treatment, they got a surprise. Look, 2 canals. The working length in this case was achieved with veterinary files. As you can see, it's a really long tooth, and the working length was actually 47.5 millimeters. Remember, our longest files that we have available to us in the clinic are only 31 millimeters long, but you do actually get veterinary files that are mostly intended for use on animals, and vet files were used in this case. But that was the cleaning and shaping, so how about obturating a case like that? Because remember, our GP points aren't long enough to extend to 47.5 millimeters. In this particular case, they created a custom-made mold in order to make their own GP. The mold was prepared with the veterinary files, and then a custom GP point was made with thermoplastic gutta percha. Here's the custom-made gutta percha as compared to just a regular gutta percha cone, and you can see that it's actually really big. The case was obturated, and there they have the 1-year follow-up radiograph. They actually had quite a nice follow-up, good success on the case, and again, these are cropped pans and not periapicals demonstrating this result. So sometimes you need to think out of the box as well, and this is my example of an obturation that's even more advanced than any of the techniques that we've described previously. In conclusion, many advanced obturation techniques exist, and all these options allow us to provide a good 3-dimensional obturation and to fill our complex root canal anatomy, especially in the apical third. But please bear in mind, please remember, even the best, even the most fancy obturation techniques will not help you if your disinfection is inadequate or if you have missed canals or anatomy in the first place. So go and find the canals. When you find them, prepare them well and spend a lot of time on disinfecting the canals, because it's more important what we take out than what we put into the tooth, but obturation clearly is still an important consideration. At times, a combination of techniques may be needed for any given case, so it's good to be familiar with a couple of different techniques. Both your warm and cold techniques can be effectively used to obturate. However, the scientific evidence that's available at this time hasn't clearly demonstrated either of the techniques to be clinically superior. So my recommendation is to use what you're comfortable with and what gives you good results, but also don't be afraid to learn something new. It's good to have a couple of tools in your toolbox and you reach for the appropriate tool at the appropriate time. That's all for today. Thanks for your attention.